I'm going to go to the cloud. Okay, and then we will proceed to our program. So we have 3 speakers on our program. We're going to start off with Andrea and Alexandria. Alexandria Drake. And you're going to tell us about an online tool of some kind that
Yes.
identifies U.S. counties and need for more medically assisted treatment options for opioid use disorder. Alexandria, take it away.
Yes, thank you so much. Well, first of all, I just want to say I'm so excited to be here. I was really excited to get the invitation, and this is my first Health Councils meeting, but I actually was just talking earlier this week with Shelly Manlev with the New Mexico Public Health Association, and her and I both had the loveliest chat about how important health councils are. And so I'm really excited to share today some preliminary work from my dissertation. As well as I'm really excited to get feedback about other things to integrate in this dashboard that I'm building that you all might find useful in your work, because the end goal, as I'll show, is to have something that's useful for communities and organizations to be able to use and take data, because data is a very powerful thing if it's in the right hands. So let me go ahead and share my screen. All right. Let me put it in presenting view. All right, can you all see my screen okay now? Oh, perfect. Okay. So again, my name is Alexandria Drake. I am a global health PhD candidate at the School of Human Evolution and Social Change at Arizona State University on the Tempe campus. I'm in my 5th year there, and the way that I kind of describe, so we call it SHESC for short, because School of Human Evolution and Social Change is a mouthful. The way that I describe the program is it's really built to apply, public health practice with medical anthropology. So my background is in public health, applied public health, but then I also have a bit of a background in medical anthropology, and it's really trying to fuse those 2 things together. But because none of you have ever met me and I'm kind of this strange random person, again, not to give you my whole life history, but I was born and raised in Phoenix. I grew up in the north central part of Phoenix, spent 6 years in the Midwest, and worked as an epidemiologist for the health department in Arizona for 3 years in their health equity office before going back to grad school. But by far the most interesting thing that I could share beyond all of that CV stuff is, these pictures encompass 2 of my favorite things, my dogs, George and Bailey, and then they are either intently watching or completely indifferent to the Phoenix Suns playoff run from this last year. So I'm a big Arizona sports fan. So it was really exciting to finally have a good basketball team, even if they weren't always thrilled about it. So you already introduced yourselves in the chat, so you don't need to do the first part, but I would just love to hear about the second question. If people could just put in the chat on a scale of 1 to 5, how easy or difficult you think it is for individuals with opioid use disorder to access medication-assisted treatment in your county, with 1 being extremely difficult and 5 being extremely easy. And this is more, there's no right or wrong answer. This is also kind of a bit of a gut check for me, because I live in the clouds of the data. I'm very much up and not in the communities. And so it's going to be interesting to see kind of how you all working with communities and more engaged in what's actually happening on the ground, how that reflects in with the data that I am looking at, because data is limited. So, okay, so I see a 5, great. We love that. Okay, 3, wonderful. Wonderful, 2, okay. And if you feel inclined to add a little bit about why, I don't know if anyone feels like they want to share their rationale, you can either say it or write it down a little bit. Does anyone have any reasoning for the number that they gave? Remote, not enough providers. Yep. Yeah. Okay. Wonderful. Well, thank you so much for being so engaged. I really appreciate that. getting a little bit at what my, I don't want to rewrite the wheel or tell you all things that you already know, but just really quickly as a refresher, or if you don't work a lot in the opioid landscape, medication assisted treatment, really the goal is that you're combining medication, so methadone, buprenorphine, less common naltrexone, and then ideally it's in conjunction with some type of behavioral therapy, either individual counseling or group therapy. That doesn't always happen because resources are limited, but in a perfect world, it would be that more holistic approach of combining those two pieces. And so that's really what my research is looking at, of how can we help to identify areas that have this unmet need for this type of treatment for opioid use disorder. And as I was, looking at data, I found that there were a lot of things that you could find at the national level, where you could compare data from state to state. Within states, they had their own kind of online tools where you could compare, but the data was often analyzed in a way that you couldn't compare cross-state. So, within the bounds of New Mexico, you could compare. Within the bounds of, on the slide, I have Arizona and Wisconsin. You can compare, but they don't always talk to each other. And so one of the things that, that kind of sparked this idea of building this national level online data set that has county level data that is comparable and is compatible, and that people can use to not only talk about how the opioid epidemic is presenting in their counties, but be able to compare it to other counties, whether it's other urban counties, other rural counties, however it makes the most sense. This slide is probably a really silly thing to share in this group, but because I spend most of my time in an academic setting, a lot of the people that I work with have either only ever worked in an academic setting or very limited capacity. And so this is actually a direct slide from my dissertation proposal defense, to make it explicitly clear what I was trying to go for and why I was trying to go for it. And that's the idea that people working in communities and policymakers, what is helpful are tools that allow data to be flexible, easy to use, and just puts the data in their hands. And when I started this project, that type of platform didn't exist when looking at national level opioid data. And I'm happy to go more into details of how I went about collecting the data, cleaning the data, analyzing the data. I really nerd out about that stuff and could talk about it for hours, but I know it's not everyone's jam. And so if you have specific questions, I'm more than happy to answer them in the Q&A. But the majority of my data came from CDC Wonder. That's where I got my mortality data, or from SAMHSA, I was able to get numbers of buprenorphine providers, the zip codes of buprenorphine providers, and make the county numbers based on that, methadone clinics, as well as prescribing rates. And one thing I'll add here, that is a major limitation of my work, and that just comes with the territory, is that I can only report on the data that's available in these national data sets. And so as we're looking, you might see your county and say, oh, well, according to this, it says that there's 3 buprenorphine providers, but I know that there's 4. That's the type of thing where, as much as I would love to go through and cross-check every single county in the United States, it's not something that I've done it at this point. And so I just want to throw that limitation out there. So I actually put screenshots in, but I'm going to see, sometimes it lets me show the maps in the online platform, and then sometimes it's really finicky. So my first choice is I'm going to try to switch screens, and so you all can see what's been developed so far. And if it starts to act weird, then I'll switch over to the screenshots. But I think it is nicer to see it in the actual platform. Also, I'm sorry, are there any questions or comments or anything up to this point? I realize I've just been rambling. Please feel free to interrupt at any time if you have questions.
Alexandria, I'm pretty sure one question that will arise or request is that we make your presentation available to everybody. I'm assuming you can do that.
Yeah, definitely.
Great.
Definitely.
Okay.
And I'll probably say this 3 or 4 times. We've had some hiccups. I was hoping this would be finalized by the time I did this presentation. I'm hoping within the next month. And as soon as it is finalized and ready to be shared, I'm planning on emailing it, and it can, feel free to share it as far as and wide as you would like. So, but let me show you the maps, because the maps I think are the most interesting thing. So the first, so I have a whole bunch of data, and basically the dashboard is going to be, you know, an online map that people can go to and select the different type of data they want to look at. But the really nice thing about it is, you know, if you zoom out, you have a really good look of the whole, you know, you have the United States, you have the United States and Hawaii. But my favorite part about the map is that if you were to zoom in, so these are crude mortality rates for 2015 to 2019. And so, you know, those familiar with the opioid epidemic in New Mexico, you know, Rio Rivas County is very high. You can actually click on the county and it pulls up a whole slew of county specific data that you can look at. And so some of it is demographic information that got pulled in automatically. So there's some census information, but then there's also information if you were to scroll down, you know, you have information about, you know, the buprenorphine capacity and things like that. So for the data that SAMHSA had for Rio Arriba County, there are 31 buprenorphine waivered providers that have a capacity of 1,840 clients or patients that they can see. And in that 5-year period, you also have 120 deaths. And there's just a lot of data in here that that you can look at. I went through and I calculated, you know, provider standardized per 100,000. And the next map that I have actually is that placed out on the map. And so the idea being that when the dashboard is finalized, it's kind of a one-stop shop for a lot of this type of data, where whether you're looking at, you know, a county or you're wanting to compare across a bunch of counties, not only is there a way for you to visualize the data through the map, you know, so you can take screenshots of it or download certain images of it, but you can get more detailed information about the different counties. And so again, you know, it's one of those things where I can't wait for people to be able to look and play around with it on their own, because I feel like it doesn't quite do it full justice to be showing you on the screen and not letting you kind of move around and play with it on your own. Oh, this one maybe decided it wants to be weird. I don't know why this platform on Zoom, it sometimes has like a panic to it and it just stops working well. So we'll see if we refresh.
Alexandra, while you're pulling that up, can I ask a quick question?
Yeah, of course.
So I think you mentioned something about it, like in every 1,000 or something like that. But for those of us who don't really understand data, will there be, at the end of this, will there be like, not at the end of your presentation, but when this map is finished, will there be like some sort of a score so that, you know, we could easily see like how bad the issue is in our counties and how much resources there are in our counties?
Yeah. So yes and no. I realize that's a pretty wish-washy answer. So one of the things that I did calculate, and I can just skip to it now, is so what I did do is I basically, without getting too into the weeds of, there's no current way that you can measure unmet need, right? It's something that if people are working in a community, they can feel that, you know, there's not enough medication to, you know, there's not enough options for people with OUD. But in terms of, you know, physical data that you can go and, you know, show to a lawmaker or show or put in a grant application or things like that, there's not really those numerics. And so with the publicly available data that I was able to find, I created one of these metrics. And so for that, there is a score. And that is what I'm calling it, the unmet need. And so with this last map, it's not exactly a score, but that's actually a really good idea of something I might look into doing. Sorry, I'm just kind of spinning off right now as I think, because this map actually designates areas with high mortality and this classification that I made of high unmet need, or high and highest unmet need. But again, that's such a small snapshot. And the thing that I don't want to have happen is that people look at this and go, oh, well, any counties in yellow are obviously fine, because that's not the case. And that's not the reality. And so that's something that I'm trying to work through right now as I'm figuring out how to finalize things, is because like this map that I'm showing you right now, you all might be the only people that ever see this map, because it might be that I can't figure out a way that to present it that's not problematic, because I want it to help counties and I don't want anything to be used in a sense where people can go, well, look, according to this map that this researcher at ASU made, you know, only these, what is it, these 5 counties have either high mortality and high unmet need or highest unmet need. Because again, this metric is something that I created and it hasn't been perfected. But I do really like your suggestion of trying to come up with some type of score to give. I'll need to think through that, because again, I would want to do it in a way that wouldn't that would benefit, right? I don't want to do anything that's going to make all y'all's jobs harder. It's hard enough. I don't want to hurt. I want to help as much as possible. That's a really long-winded answer to your question.
Well, thank you. Thank you.
So yeah, so this is something that I've been grappling with the last week or two, and I've been working with my committee on how to best deal with this. And I don't know if anyone here has ever had the chance to meet Mary Alice Scott. She's a faculty at New Mexico State. She's on my committee. And so, you know, it's something that I need to talk through more, because this is the map in the current state and I find it a little bit problematic. So if people have any ideas or suggestions, I'm all ears. But you know, the maps that I kind of skipped through, you know, this one's the ratio map. And so really, I'll zoom in a little bit. What this map shows is for every, the way that I describe it, because numbers are not my forte. I really have to push myself a lot to do data because numbers do not come naturally to me. So the way I like to think of this is for every provider, how many deaths on average can be expected, is the way that this ratio kind of comes out. We have the mortality rate and we're dividing it by the standardized provider rate. And so, you know, we see these higher counties for every provider that's waivered to prescribe buprenorphine. These are how many deaths can be expected. And so in counties that have these higher rates, you know, it could lead to the argument of, you know, maybe we need to get more providers that are able to prescribe these medications. So then, you know, that rate goes down. But again, it's just such a small snapshot. And that's the thing that I'm really trying to work through is the data only tells part of the story. And that's part of the reason why I chose the program that I chose at ASU, is because a lot of times people can get so focused on the data, and that's not to say the data isn't important, but if you don't have the additional piece of recognizing that there's going to be, you know, variations and driving factors that are beyond the numbers, then I personally don't think much progress is going to get made. So, which is why with this dashboard, you know, I'm going to have this data information, and then I'm also developing. Right now, I'm using the term needs assessment. That'll probably change, but basically, it's a tool that can be used to kind of help guide the ways that this data can be used in a beneficial way, in a helpful way. And one of the things that I am going to do with that is I'm actually piloting it. I'm going to do a pilot myself where I'm going to be conducting interviews in 2 or 3 counties in New Mexico to not only get an idea of perceptions of access to treatment in those counties, but also get an idea of cultural and structural barriers to getting medical providers engaged with treatment. And again, that might be something that from the, you know, the professional side, the applied, you know, the working side, I know I talk to people and they're able to list all these reasons. But currently in the, you know, in the literature, there's not a lot on it. And so the idea or the hope is that by getting some of this common knowledge that you all have, it's amazing the types of conversations that I have with people after looking for months of something and through journals of, you know, oh, I wonder why this is. And then I talk to people that work in the community or in communities and they go, oh, well, it's this, this, and this. There's so much knowledge that there's just this big disconnect right now. And that's something that I think is unfortunate and something that I hope changes, that there's not quite this silo between the academic realm and the realm of those working. oops, sorry, I just saw the chat. So again, I went through the map very quickly, but I don't know if there were any questions or anything that people wanted to see on the map before I pop back over for the last couple of minutes. It's a little fast and furious, but okay. Well, I'll switch back over. Yeah, I think once it's finalized and I'm able to send it out, being able to, play around with it is going to be really helpful. And like I said, if people have suggestions of how to present things in a way that is not going to be detrimental, or if there are things where you could say definitely don't do that, it doesn't have to be ideas, it can also just be a definitely don't do this. So the next steps of where I'm going from here is, I'm going to finalize the dashboard and hopefully add any additional information that you all think would be helpful. This is something that I'm developing for community organizations to use. So if it's things like, what would be really helpful is to have socio-demographic information or socioeconomic information, or it'd be really helpful to have whatever type of information, work on building that. And then, like I said, I'm going to be doing those deeper dives in 2 or 3 counties to really focus on those facilitators and barriers. And part of that is also to check the data. When I go in these counties and I try to get a grasp of what's going on in the counties with the opioid epidemic and access to treatment, is what I'm hearing from people that are the experts, those are the people I trust, is that matching what the data is showing? And if not, what are ways to address that? How can we mitigate that? Because again, I think there's a lot of great data is great, but sometimes I think too many people take it as an end all be all. And I think we need to make sure that the data is actually correctly representing what it's showing. And so that's kind of the goal of this. I guess if I were to sum up my entire 25 minutes into that, that's really what I'm trying to look at. So be on the lookout for participating. There is an incentive. I know your time is very valuable. And the other thing that I worked on for my dissertation, which I'm going to touch on really briefly, but it kind of gets at the same idea, is that I spent the last 1.5 years working with 4 undergraduate students to conduct a review of literature, peer review literature about demographic differences in opioid mortality. And what we found was that studies would often present data on these demographic differences. So, it could be variations in opioid mortality by race, ethnicity, age, sex, gender, location, urban centers versus rural centers. But very rarely was there ever any reasoning or hypotheses about why those differences exist. And it kind of gets at this same thing for this last slide of both the dashboard and this. What I'm trying to get at is that, for the dashboard, if we don't have the context, if we don't know the context of what's driving this information, and we're just looking at only, the maps and, oh, they're colorful and they're nice, but we're not looking at the things contributing to those differences, there's only so much we can do to fix the problem. And I feel the same way. And that's what I'm currently writing on this paper that follows up with this review, this literature review, is that if all we're doing is talking about here are the differences in the opioid epidemic by demographic groups, but we're not trying to get at why those reasons are, there's only so much we can do to help and stop and mitigate the epidemic. And I think part of that comes with the realization that it takes a lot of effort, because things are going to present differently in different groups based on a lot of factors. And even if you look at New Mexico, the way the opioid epidemic presents in one county with certain demographic groups is different than in another county with certain demographic groups. And so it's a lot of taking the time and energy to focus on these individualistic driving factors, which is where kind of the medical anthropology portion of my studies come in. And so both of these projects are really trying to move this needle of better bridging public health and anthropology, because I think both fields would really benefit from more integrated projects between the two. Yeah. So anyway, when I practiced that, it was much less rambly. So I very much apologize. I feel like that ended up being way ramblier than I meant for it to. I feel like I got on a little on a soapbox a little bit. Also didn't mean to. But if we have any time, I would love if people have questions, I'm happy to answer questions. My email's here. Feel free to email me. But if people have any ideas of other things to integrate into the dashboard, I would love to hear it. If you have ideas of things to avoid with the dashboard, I would love to hear it. Again, I spend so much time in a very cramped, no windowed office in a university that feels so distant from the communities that I'm working with. And so I would just love to hear any insight that you all have if you're willing to share.
I wanted to draw attention to the comment from Morris White. Can you
Oh,
address?
yes.
Morris, yes. Do you want to unmute and just explain your comment a bit?
Well, I'm hoping that this dashboard, with us communicating and trying to figure this out nationally, I'm hoping that it will help within states like ours, just to communicate within itself, because
Yeah.
we seem to have a very difficult time here between the different counties. We have 30 something counties here. So just communicating, and most of New Mexico, is spread out, and you just don't get to see these people that need the help.
Yeah.
And we're working on that in Sandoval ourselves. I mean, we have the Pueblos here, outside of the Albuquerque area in that county. It's just really challenging getting to people and helping them. So, I mean, I love your work. I really appreciate what you're doing, really do. So hopefully we can make this bigger.
Yeah, and I mean, and that's a really good point, because New Mexico, is not alone in that. And obviously all the states vary, right? But I just mean that to say that, I'm not trying to say that the experience in Arizona is the same as New Mexico, because it's not. But one of the things that I would hear a lot when I worked for the State Department in Arizona was people would call it the state of Maricopa, because in Arizona, of the majority, 80% of the Arizona state population lives in either Maricopa County, where Phoenix is, or Pima County, where Tucson is. And
I was there.
Yeah. And so, it's similar to what you're saying, is that, in talking to other counties, they would often express a lot of frustration in terms of, the logistical considerations of providing care and accessing care in those communities wasn't always taken into consideration the same way that it was in the urban centers. And, a lot of time and energy and resources would go to these urban centers, which, yes, the most of the population lives in these places, but then the smaller counties, or the more rural counties, felt, kind of like they were being left high and dry. And so, I completely understand. Like, I know what you're saying, that, counties have a hard time communicating with each other. And that's the thing that I should mention, is that this is also something that I'm planning on continuing. I feel very invested into this at this point. And so, what you all are seeing now, so actually you all are the first to see any of these besides my committee and the people that I work with directly. And so, the way I'm hoping it'll be is that, it'll kind of be stages of launch, that, this first initial launch is going to be, the stuff that I have now presented in the best way as possible, but then really actively taking the time to engage with people and get feedback to hear, how are ways that are there ways that this can help facilitate in helping with some of this communication effort between counties, whether within the same state or outside of the same state.
Well, Alexandria, I'm so glad you said that, because you can rest assured that we are going to continue this conversation with you.
Perfect.
And thank you for introducing it to us.
Yes.
I do want to be sure that you are connected with our New Mexico Community Data Collaborative. Are you connected with them?
I'm not.
Okay, so they are doing very similar work as yours.
Okay.
And they are crafting dashboards for each of our counties.
Oh, fabulous.
Critical data. So we will be sure and put you in touch with them. and we can all work together, because that's very important in New Mexico. We have to work together. We don't have the
Yes.
resources to duplicate efforts. So
Yeah.
thank you so much. I know there are a lot of questions still, but you've got Alexandria's email. We will keep in touch. We'll have her presentation sent out to all of you. We'll get her in touch with NMCDC. And I expect some of you counties, community health councils, will want to volunteer to interview with Alexandria. So let's make sure that we make those connections as well. Great. Okay. Any conversations? Yes. Thank you so much, Alexandria.
No, thank you so much for having me. And again, I'm sorry, it was a little rambly. It's the end of a crazy week, so normally I feel a little bit more composed. So thank you for bearing with me there.
It was great. Thank you so much, and I hope you can stay on the line.
Yes, I'm very excited.
Great. Oh, I did want to point out, Diana, I did see, look in your chat, folks, because Diana has posted a flyer. Diana, do you want to explain briefly what you just posted in chat for all of us?
From my understanding, DOPE Services will mail anybody harm reduction supplies that needs them in the north. It says northern or southern New Mexico. That's the whole state in my estimation. So call them and see what they can do for folks with either disabilities or live in rural communities. That's
Diana,
everybody.
Would you add your email to the chat just so people can get in touch with you if they have more questions? Okay, well, thanks so much. Well, next up, we're not done. Hang in there. Next up, we have Cassius Loya. Am I saying your name correctly, Cassius? Who is going to be
Yes,
talking.
that's correct.
Oh, good. Okay, another opportunity for you all to contract with him on community-based organization and rural community recruitment. Say more, Cassius, please.
Okay, I'll try to keep it short. I know, I hope everybody's having a happy Friday, looking forward to the weekend. My name's Cassius Loya. I've worked in healthcare now for about 10 years. I do recognize some of the names on there. I don't know if they remember me, especially Miss Joanne Palomino. Worked with her quite a bit down in the southern part of the state. Currently, I live in Roswell, but my job brings me out to Albuquerque a couple times a month. I'm currently the Outreach and Enrollment Manager for the New Mexico Primary Care Association. I'm sure quite a few of you are aware of what the Primary Care Association does here in New Mexico, but for those of you that aren't, the Primary Care Association is a 501c3 nonprofit organization consisting of about 19 partner organizations, and those partner organizations have about 160 clinics, school-based clinics, or different healthcare locations across the state of New Mexico that are either federally or state funded. And what the NMPCA does is act as kind of a liaison between those organizations and the state and federal governments that fund them. So for New Mexico, like I said, we have 19 partner organizations with over 160 locations. Right now, as I'm assuming a lot of you know, we're just about to start open enrollment for the marketplace for health insurance here in New Mexico. And this is an exciting year for those of us in the know, because this will be the first year ever that New Mexico will not rely on the federal marketplace to get folks insured, but has implemented a new state-based marketplace. So all the plans will be from New Mexico for New Mexicans. And it's been a thing that's been 2 years in the making. New Mexico Primary Care Association has partnered with Be Well New Mexico, who is running the marketplace for outreach and enrollment. Now, and I'm sorry for the background noises. I was at a conference and I'm just driving down the freeway and I had to stop somewhere with Wi-Fi. So what we've done is partnered with Be Well New Mexico, and what we're trying to do is locate and find organizations that are willing to partner with us and contract with us, especially more rural organizations that have staff or folks that might want to become certified enrollment counselors for the state of New Mexico, that would be able to educate, do outreach, and enroll folks in the marketplace once it opens up November 1st through January 15th. We partner with those contract organizations. If you look on the Be Well New Mexico website right now, it gives you the stats of who can become an enrollment counselor. But on our side, on the NMPCA side, we're looking for organizations that we can partner with and contract with to be able to provide compensation for any outreach, education, and enrollment that they do in their city, in their county, in their towns that might benefit, New Mexico residents that don't have current health insurance. It's a pretty lengthy process. Well, the contracting is, but to become an enrollment counselor isn't too bad, especially if you've done it before. Most of your local federally qualified health centers, for example, in the Roswell, Clovis, Portales area, that would be your Las Casas. In the Albuquerque area, to be something like First Nations. Down south in the Las Cruces area, Ben Archer, La Clínica Familia. Those are all partner organizations with NMPCA. Those organizations are contracted, so those would be the places you might want to go if you needed help with Medicaid or marketplace enrollment. But we're trying to look at other venues, different organizations that aren't necessarily healthcare organizations, but that are involved in the smaller communities, maybe chambers of commerces, local health councils, such as the health councils that form this organization and this alliance of health councils that might be willing to help out their communities and be compensated for that. If you guys have any questions about that at all, I know it's a lot of information right now. Once we contract with an organization, that person, like I said, would be in charge of managing, their enrollments, their outreach, anything that we do. We would obviously send them materials to help with that outreach, get them in touch with the outreach-based teams that are here in Santa Fe and Albuquerque that go down and visit the counties to create events, and invoicing us to be able to be compensated, and also allocate and enter data into our New Mexico Primary Care Association dashboard. I know it's a lot of information. I wish I could have had more of a presentation ready, but this has been a crazy, hectic week. Like I said, compensation is great, and that would be based on hours per month and how many enrollment counselors are associated with the organization. Obviously, we pay for the training as well. Training can take between 8 and 24 hours, and it's all self-serve through the computer. So does anybody have any questions so far? I know I said a whole bunch.
Questions, anyone? Before we forget though, Cassius, would you please put your email into the chat?
Yes, I will. I had to stop by a Starbucks to get Wi-Fi, and I wanted to step outside. That way it wouldn't inundate you guys with some music.
Do we need to put your email into the chat for you?
No, I will just
Okay.
run in and press the button. Give me just a second.
Okay, great, thanks. Any questions? It sounds like a great opportunity. Anyone want to explore this further? If you don't have a question at the moment, there is his information. You can get a hold of Cassius and explore this a little bit further.
So I put the information in there. Also, there's the website to learn more about NMPCA. Like I said, the organization so for example, if it was a local chamber of commerce that wanted to partner with us, that chamber of commerce would say, we're made up of so many members of the community. These 2 members want to become enrollment counselors, and that chamber of commerce would be the contracted organization. And there wouldn't be a minimum amount of work. Like, let's say, there isn't a quota to be met. This is just based off of any enrollments or any outreach that you might do in the community to help people become educated on the new New Mexico state-based marketplace for health insurance.
Cassius, thank you so much. We're discovering that, of course, we don't have enough resources. We need more resources in New Mexico, but an equally difficult challenge is that people don't know what's available or they don't know how to access what's
Yes.
available. So any help that community health councils and your members, anything you can do to help people make sure they have health insurance coming up.
Yeah, and right now, just something to think about. And, it's just something that if you're not in the healthcare industry, right now we're in what's called the public health emergency that was issued at the beginning of the pandemic, where they increased the levels of persons that qualified for Medicaid. Starting January, December 31st is going to be the end of the public health emergency, and they're going to start rolling off people from Medicaid because those limits are going to decrease to where they were before.
Yeah.
So there's going to be a lot of people that are going to be left without Medicaid that were on it for the past year and a half. So those folks are going to be the ones that might be able to qualify for tax credits on their insurances if need be for the following year. They're estimating at least 120,000 people that were on Medicaid will be rolled off within the first 6 months of 2020. And we'd hate for those people to have a gap in coverage. We want to get New Mexicans, the health care that they need, especially we all know that, well, I know being from the South, bringing my parents up to Albuquerque or Santa Fe or to Lubbock every month or so to see their specialist can be extremely tough. So we don't want to make anybody's lives any more difficult with having to have the headache of dealing with not having health insurance. So I think anything that we can do to help people out is great.
Great, thank you. And we'll make sure again that all of you get this information coming to you via email shortly after this meeting. Thank you, Cassius, so much. That's so important. And we do have your contact.
Yeah, like I said, yeah, and I'd be more than happy. Like I said, I'm sorry about the current situation I'm in with traveling, but if you guys want to send me an email, if you think your organization might be, interested. I know there's a gentleman on the call from Sandoval County. This morning, I talked to the Sandoval County Health Committee. There's 2 guys that were enrollment counselors in the past that are going to re-enroll. I just talked to them this morning. So, everything's connected. So if you guys have any questions, anything at all, don't hesitate to bother me. It's not a bother at all. I'll be more than happy to send you some approved information or anything you might need.
Okay, great. And feel free to get in touch with your Alliance staff too if you need additional information on how to contact these folks. So
Sure.
last and not least, thank you, Cassius. Last and not least, Mary Feldblum is representing the Health Security for New Mexicans campaign. And she's going to tell us about the superintendent's efforts regarding a plan for universal health coverage for New Mexico. It's known as the Health Security Plan. Mary, you have like 10 minutes.
Okay.
Begin to let us know what's going on here.
Okay, it's wonderful to be here. What always strikes me listening to Alexandria and Cassius is we have so many problems facing us in New Mexico and elsewhere around the United States. And the data collection, the programs that are developed here and now are really critical. But what I want you all to think about is what's wrong with our system. Why we really need to think carefully why health costs are always increasing. We may get people to sign up for insurance, but then the premiums go up or their deductibles are increased. Physicians and other healthcare providers are very frustrated with the complexity of our system. The Mayo Clinic has a study that says physicians actually spend twice as much time looking at computers than they do at their patients, and the time that they spend with all the coding. Hospitals, our rural hospitals are in big trouble. And all of these were flags prior to COVID. And I think what COVID has done is exposed a lot of the weaknesses. So the Health Security for New Mexicans campaign is the largest coalition in the history of our state. It's 170 organizations, includes the ASACI Association, the NAACP, the All Pueblo Council of Governors endorsed this a couple of years ago. And the idea is let's set up our own health plan. And you are the administrative simplicity and making the insurance industry no longer be the middleman is enormous savings. I mean, there have been 3 studies done in New Mexico that show rate of increase in healthcare costs will save millions, hundreds of millions of dollars within 5 years. And that, of course, those savings can be used to invest in good programs that we need. All the programs that you all want require funding. And so here's this plan that's been worked on for many, many years. The sponsors of this, Representative Debbie Armstrong and Jerry Ortiz-Pino, have been working on this so that you have freedom of choice of doctor, geographically representative co-op, like, you know, so it's not dominated by Albuquerque and Santa Fe. And it, you know, the studies that have been done have been projections because they don't know exactly how much doctors will be paid or hospitals will be paid. So what the sponsors decided is we need to switch gears a little bit. Instead of introducing the Health Security Act, which is a well thought out plan, the idea is let's design it. Let's figure out the details. And it's going to take about 3 to 4 years to do this. And at the end of that process, when it's designed, then you can do a cost analysis of the plan as designed. Alexandria, you know numbers, and there's so many projections. And you know, if you don't, you know, the more you know, the more you figure out the cost. And you won't know how you'll pay for it until you know what the cost is. So that's the process. And last session, thanks to actually 7 legislators, $575,000 was appropriated to the superintendent of insurance to oversee the health security plan design process. And we have found so many of our supporters. I mean, it sounds great to have our own health plan, freedom of choice of doctor, but there's a lot of details that need to be worked out before this plan can be up and running. We're the first state in the United States to actually say, gee, we're not going to be general anymore. We're going to be specific. We're going to roll up our sleeves and figure out the details. So the superintendent of insurance has decided that he wanted to hire consultants to do some basic research. I talked to many provider associations and I said, what do you think the solution is? You're frustrated, you know, with the current system. What do you think the alternative is? And they don't know. You know, all they know is the frustrations. And so this first set of research that's going to be done is informational. It's going to provide us with a lot of good information and with public input, and your role is going to be very important in this process, as well as providers, as well as hospitals, to begin to figure out the details of this plan, what will work. So the 4, first of all, I'm going to email you or chat with the chat. The superintendent of insurance is going to do a presentation on Tuesday about the status of this design process. And you are welcome to join it, but it's a Zoom, you've got to sign up and get a code. So there's the email for you to let Josette know that you want to attend. It'll be at 6:15 to 7:30. And I encourage you because you'll get a lot more information. And I know I see the time is getting short. So let me give you a brief idea about the 4 topics. One is to know about the waivers that you know, if we're going to set up a health plan that's going to include almost all New Mexicans, as many as we can. Medicaid is clearly clearly one very substantial population. And so what can be done? You need a waiver, you need a permission. There are real problems with rate payments and Medicaid to providers. There's a whole lot of difficulties. And if you kind of include, is the whole idea of old-fashioned insurance, you include almost everybody, you're sharing the risk. You can actually increase payment rates to providers mathematically for Medicaid. And you're simplifying overhead because they're not dealing with many of the providers that deal with Medicaid patients are also dealing with other insurance plans. And it's not just Presbyterian. Presbyterian has 10 different policies with 10 different rates for the same procedure. We have the most complex, complicated system in the world. It is really shocking the amount we spend on healthcare administration instead of services. So who can come into this plan if with Medicaid being a focus? The tribes are sovereign nations. We've had lots of discussions with them, and they can decide how they want to fit into this. But there are federal issues that would have to be considered. The second issue is provider payment methodologies. And by that, I don't mean the exact amount. You have to figure out what's the method you're going to pay with. Fee for service is bashed in the United States all the time. And what has happened is we see that what's called risk-based payment systems are given to be the solution. What do I mean by a risk-based payment system? You give a provider practice capitated rate. So per patient. So all of a sudden they have some high risk patients, right? And they're going over budget. The risk base says it's your fault. You know, you've got to figure out how to handle all your patients at X amount of rate. There's other kinds of mechanisms that are used. There is something called, and you can go on our website, www.nmhealthsecurity.org, and learn about what's called an all-payer payment system, which all the industrial countries that have universal coverage do. Imagine you go to a doctor and get a physical, and it's the same rate no matter where in your country. It simplifies things no end. How it works is very complex, and it's done differently in Japan, it's done differently in France and Germany. We need to learn about that. Let's find out how they do it and see what would work that's smothered in green and red chili. We're not going to imitate any country or any system, but let's figure out what's out there. So figuring out the provider payment systems, I can tell you, we've got the Medical Society, the Academy of Medical Family Physicians, the nurse practitioners, the Oriental medicine docs, the psychiatrists, the psychologists. They are so excited. And these consultants that have been hired are going to meet with, prior to the research, to talk to providers about what they would hope to get from this research. Decisions are not going to be made. I want to make that clear. This is informational. The other
Mary,
yeah.
I hate to interrupt, but we are going to have people who are going to have to leave in about 2 minutes, and I don't want them to miss whatever information you want to be sure people leave here with.
Well, I want them to sign up if they can for this superintendent's report. So they'll get to know more detail about the research, particularly something called global budgets for hospitals, which is absolutely critical, and here and now. And in addition, they will learn who the consultants are. And certainly everybody should ask, how can we get involved? Our big issue is to continue the funding for this. Okay. This was only the first year, and we need to have, and Representative Armstrong and Senator Ortiz-Pino are going to request $600,000, which at a $2.4 billion surplus we have is really nothing when you're investing in a big picture solution that can help the here and now as well as the long term. Our website, by the way, is www.nmhealthsecurity.org. You can get my email there, and you should have lots of questions. And I'm going to be presenting, I think, at another date to you also. You'll have, I hope, lots of questions, because I think many of you probably have never even heard about this. But we are so far ahead of any other state in terms of thinking just the idea. And think of the Health Security Act as a recipe, and we're the cooks. And okay.
Mary, thanks so much. So it sounds like can we also sign up for the superintendent's presentation on your website?
No, you can't.
You cannot.
You cannot. So, that's why I have given you the, you need to contact Josette, and I put in the chat the contact information for Josette, which is, think of Health Security New Mexico campaign, hsnmc.contact@gmail.com.
Madeline, could you put that in the chat again real quickly? Thank you. Okay, gosh, this was a lot of important, complex, but very important information for New Mexico. Thank all three of you. It's clear all of you are going to have to come back and talk some more. And we're going to have an ongoing conversation with all of you. We're going to post as much information on our website as we can to make sure that we don't lose track of where we are in these conversations. So Madeline, could you also put up with the closing slide? We have additional upcoming information, events we want you to know about. So again, all of this information hopefully will be on our website very soon. So nmhealthcouncils.org. Check us out. Get in touch with us. Let us know if you have any questions or suggestions for how we can keep this conversation going. And thank you all so much for being here.
Thank you.
Together, we can do this. Yes. Thank you.
Thank you.
Thank you very much.
Thank you all.
Thank you so much for having me. I just
Oh,
wanted to
Alexandra.
say thank you.
Alexandra, we will get in touch and you definitely
Perfect.
need to connect with NM,
Yes.
NM Community Data Collaborative.
Yes, definitely. Yes. for
Okay.
Sure. Wonderful.
Great.
Have a great rest of your day. Have a nice weekend.
You too. Thanks so much. Okay, Madeline, sheesh. We had some talkers. I hope I wasn't rude to anybody, but Madeline, we're gonna have to figure out seriously how to get this information on our website, capture it, keep it fresh, keep these conversations going. So you, Gerald, I, Sharon, Susie, all of us are gonna have to have a conversation. This
Okay.
is incredibly critical. All those people getting bumped off Medicare.
Yeah. Oh my
Okay.
gosh. I was like,
Oh my
125
goodness, but this
people?
opportunity to be certified enrollment people, super role for our health councils. I'd love to have our own state insurance thing. I wish we didn't have to wait 3 years, 3, 4, 5 years for it. I wish we could do it now. Oh my goodness. Okay, we got to
Yeah.
get on to, we're the ones that have to pop off now. So we have to go to
Okay.
this other meeting at 1. But
Okay.
are we going to get, not on Monday, but you and I are going to get in touch again on
On
Tuesday?
Tuesday. Yes, that sounds good.
Okay,
And
let's see if we can get Geraldine in on, I don't know
Okay.
what our agenda was for Tuesday. I can't remember exactly, but should we get Geraldine back in on that too?
sure. Yeah. I'm trying to remember. I think it was a lot of website stuff and then maybe some other things as well. I can check, but maybe
Okay.
if there's an invite already, I'll add her to it.
Yeah, add Geraldine.
Okay. Sounds good.
Okie dokie, thank you.
Yes.
See, we're going a mile a minute. I'm so glad you're here.
Yeah.
All righty, Madeline, thanks.
Okay. Yep.
Talk to you
later.
soon.
Bye.
Bye-bye.